the next in the program. And we don't have breaks. We have open coffee. That means whenever you feel, you go outside and you have have a coffee. And you're here until you want to see. If you don't want to hear something, go outside. It's a very beautiful veranda.
Next, Dr. Huning. He's going to show us. We're moving towards the anterior segment, so it's a nice technique to bagel.
Yeah.
And he's going to show us his technique.
One of the great young surgeons, Matteo Forlini, is here behind you. He's the pianist of the group, and he's the one who's going to teach you how to do iris suturing. He's the specialist in the world. And now you're going to see Guastavo Huning. Guastavo Huning used to be our student like you, not young one, when he was a few years ago. And then he went to Brazil. He became famous in America, and he started up a clinic. There is the thing that they call the Huning's Clinic, because his father is ophthalmologist, his brother is ophthalmologist, so they take up the whole area. And then they decided to take, you take this million people, you take this million people. So he's in a jungle. What's the name of the place you are, Guastavo?
Santa Maria.
Anybody know Santa Maria?
Holy Mary.
Holy Mary, yes, we know. This is, but do you know where it's in Brazil? So he has a complete different social economic stuff of what we do. So he has to do with the least possible expenses, the best kind of surgery. And he's going to show you some tricks and tips that he has. Thank you, Guastavo, for coming.
Thank you for the invitation. Yes, I think it's in the pen drive. 1 second. It needs to open from here. 1 second. Let me just open here. So while it's loading, thank you everyone. It's a pleasure to be with you again. Thanks, Anassis. I did this course as a student in the year of 2015, if I'm not wrong. That's 7 years ago, and after that I kept coming every year, because here is maybe the course in the world where you'll have the greatest chance to interact with the lecturers. It's not like a big meeting where they are always running and going. And so I hope you enjoy the time you'll have here, because it's really a great opportunity. Okay, what's happening here? I just had it. So, thank you for your patience. Let me just start here. Now, yes. So the thing is, here when Thanasis asked me to prepare this lecture, I have spoken something about it last year when I had to participate online due to the pandemics. It's because we have people here from all corners of the planet. So I hope this might help you a little bit. And these are things that I learned myself on the hard way. I wish someone had told me all these things I'm gonna tell you before. So I hope it helps you. So first thing, what is a commodity? Nowadays, with this economic crisis after pandemics and after inflation, that governments are putting the guilt on us when they have printed as much money as more in the rest of the history. Everybody knows a commodity when we talk about oil, okay, petroleum. But commodity can be many things, and you have the concept here. The main one of them is your time, because time is a commodity that you cannot recover. If you lost a second, this second is lost, okay? There is no way you can run back or recover it. So, spend it really wisely, like your wealth. Something for people like us who works in poor countries, if you increase quality, costs go low. It's really difficult to understand and to accept that when you are starting, because most of us, or many of us, don't have all those resources to start. We have a bad machine, we don't have the best consumables, but as long as you start to improve your technique and to learn, you're gonna see when you use better things, better consumables, you're gonna spend less time, and that's what you wanna buy when as much as you can with your work, with your knowledge, is time. Always focus on time. Okay, I want to make more money. It's really important, of course. Money doesn't bring happiness, but the lack of money for sure doesn't bring you as well. Chair time. Speak with your patient before the surgery. Explain and work with him about the expectations, because if you give him big expectations, like Thanasis told about the patient, okay, you're going to make a phaco now and you can leave to your home driving by yourself. Never promise that, okay? Never promise that, because you're going to be in trouble. It might happen when you are very good or very skilled. Of course it might happen, but you shouldn't. Checklist. Always have a checklist before starting to operate. Okay, but that will take me half an hour or maybe 1 hour. Prepare your team, repeat, check, because imagine you are in the middle of a surgery and, for example, you have a posterior capsule rupture and you need a 3 pieces IOL. Oh, wait, doctor, we have to check if we have it, or wait, because we have to go to the other side of the hospital to get it in the pharmacy, then bring it here, make all the paperwork, and then implant this IOL. So check if you have everything. Check if the compressor is working. You don't want your vitrectomy machine stopping during the surgery, okay? All this basic stuff, all this minimal stuff are complicated. Look if you have all the instruments on prepared to you. For example, if you have a falling IOL, you want a small forceps to hold it before it falls to the vitreous. You don't want that, okay? So this is maybe from all the things I'm going to tell you, this is the most important one. Anesthesia. Find an anesthesiologist who you like or you trust. Because if you have a guy who, when the patient is always feeling something or doesn't stop, or you have to convert the surgery and cataract to an extracapsular and the blood pressure is high, and you have an explosive hemorrhage, it's going to be tragic. For many of you, this might be really funny, but for me, this is really serious. I just started use surgical fields with plastic bags this year, because before of that, in my hospital, we could not afford it. And it changed my life because it's so quicker to clean the room, to bring someone to, we don't need to mop all the floor. So this is something that I had to convince the team that we would make money using it. Okay, but this costs 5-10 times more than what we are using. Yes, but we're gonna increase the number of surgeries we can do in a day. And I showed them, I proved them, and now I'm doing more phacos than I was doing before. The quality of the consumables. In our hospital, we have a Stellaris PC, and they had these plastic trocars, and it was a mess. Many of you who know it, when you had to grab it or to pull it, the plastic was in the sclera, and you have to work or try to find a way to take it off, and it wasn't very easy. Now, for the last years, BL is making it totally now in titanium. It's much easier to work. Second thing, probably most of you, if not all of you, are here to learn about retina. I love working with many things that you can see here. First one, non-contact system. When I start working, there was no biome, okay? And we had to use a contact system. The thing is, after 1 year, I had a nurse who I taught how to use, how to hold the lens. Many of you know how difficult and how tired you might be after 1 hour, or if it is an eye with a low pressure, it's hypotonic, you don't see very well. After 1 year I had trained her, she left the clinic, so I had to start again. And this happened really, really frequently, okay? So after 3 nurses that I had taught and left me, I realized that I should buy a biome, okay? I don't have any financial interest, but any non-contact system is something you should try. And visualizing is much more important than having a good vitrectomy machine, so think about that. The other thing you see here, it's the chandelier and accessory light, because if you want to see inside the eye, you want to have a good visualization, you need light. It's dark inside there, everybody knows it, okay? So think about chandeliers. Here I just talk about both. That's another thing very important Thanasis had just shown us, okay? Using dyes or chromovitrectomy, there is a phrase that I learned with an Egyptian friend: there is more vitreous inside the eye than you think. Use triamcinolone. There is always more vitreous. It is virtually impossible to remove 100% of the vitreous, and you don't want to provoke any breaks or any traction. Same thing with the brilliant blue, okay? I don't know if now we don't have Americans here today, but if it is already approved by FDA, they had to use the ICG, and it's not the same thing. Use a good brilliant blue. I, in the beginning, also used a cheaper brilliant blues. I had to use many times because it wasn't able to tint the ILM properly. Here I'm going to show you another, and as long as you start to work and you find other possibilities, here I learned with a friend from Bulgaria, Dr. Mishev, to use fluorescein, which is 10 times cheaper than triamcinolone. And look how beautiful it is. You dilute it, okay, here I'm using 0.1%, and I inject about 0.1 cc. I can see the vitreous very well. I can see the retina is totally detached, so I go slowly. Another thing that I should have used here, and it is on purpose, one thing I have forgotten here is to insert PFO. We don't want to spend sometimes with PFO because it is expensive, especially in our area. But with PFO, I would have done this vitrectomy much faster and with much more safety. I wouldn't be risking myself to provoke another tear in the retina. Slowly I do, and you can see that slowly this retina starts to reattach. But the thing is, why haven't I used PFO? Now I'm looking at that and I feel an idiot because my time is much more valuable. I could be back home much earlier with my family, to sleep, to go to gym, to go to movie theater, things that are more important than ophthalmology.
Sorry, can you just say the percentage of fluorescein that you use?
Of course, in Brazil, fluorescein, the eye drop that we use in the office, it's 1%. So I take 0.1 and I complete with BSS, okay, 0.1%. And you can do less. I have tried already 0.05 and it works as well. And then you inject as much as you want. I never had any toxicity problem, okay? And it's much cheaper than triamcinolone, you know. Where are you from?
South Africa.
Okay, more or less like Brazil. I haven't never been, but I know we have some things. The good things about it is that you can see it very well. Here, I don't know if we can turn off these lights because the image is not as good as here. Is it possible? Let me just pause here.
If you want to have a nice video with a big video, you must have a video without a lens. You must make so many people do cataract operation in order to have a nice retina surgery. And if you want to show a nice video, you know, you must have without lens.
Absolutely, yes.
The illumination you need to have for a video is 5 times more than you see yourself. So yourself, you see very beautifully. But in video, you have 5 times less. So if you want to have a book, you need to have chandelier lights in order to have a nice video. This is the technique to produce a nice video. And here I think it's, you don't have an IRL.
No, it's a natural lens, and you're sure. Also, we increase the pressure a little bit, so you have some kind of edema in the lens, and it's difficult to see, but keeping.
And also, it's a very wide-angle lens. The zooming is too much, and when you got that much zooming, you lose the resolution. So with a microscope, zooming means resolution loss. With an ingenuity, zooming is okay, resolution is not lost. So that's another difference. There's beauty flexibility here.
And the thing is here about using quality and improving. Here I'm showing some digital filters. You're going to see the next days with Alan Franklin as well from the Ingenuity. And the combination that we are just scrolling, we don't know everything. The combination of digital filters with the dyes, it's amazing. Because you have, so as long as I change it, how many different ways I can see. This is a diabetic patient which had a detachment after injecting anti-VEGF. It was sent to me, and the colleague didn't review the periphery, and it had already a detachment, a traction, and see how the posterior hyaloid is adhered to this retina, okay? And the thing is, I start very slowly, very gentle, but there is a point that to remove all that posterior hyaloid or that ILM, I need to be a little bit more rude, let's say, with the retina, okay? And then I start having breaks, otherwise this retina wouldn't reattach. And I go as far as I can, but as much as I go closer to the periphery of the retina, breaks will start to appear. But the thing is, visualization is really, really important, if not the most important thing about it, okay? Let's go to the next.
You know, another top story about TVRS is that on Thursday and Friday, there's going to be a guy named Michael Cardamone. Michael Cardamone is the one who did Ingenuity. So you have the same thing with Carnevale. You have the poet to ask about his poem. So Huning is going to leave us before Michael comes. So
it's a pity.
You have to share. Half of you is going to say them for Michael, and he's going to tell about you.
I just know Michael by WhatsApp, and we have changed so much information during the pandemic. It's a pity that I won't be here. But anyway, very important. Make questions. You paid a fee to be here. You paid flight tickets, you are paying food, and you are paying with your time and your attention. Why social networks are going so well? Because they are stealing the most valuable thing we have. They are taking your time and your attention. So use the time here to ask us, to talk to us. We don't know everything. We have made so many mistakes, and we are going to make many others. So use your time here. This first part, I'll finish with this, okay? Ask, talk, send message, send me on WhatsApp. Go to Instagram, talk to Thanasis. Thanasis, I have a case from a dropped nucleus inside the eye, and I don't know how I can do it. He will be more than happy to talk to you. I have many people to whom I talk nowadays, and don't feel, how can I say, afraid that people will laugh or you are dumb. No, to be dumb is not to make any question, okay? Here's my info, and then I'm gonna show you my second video. Thanasis, your considerations before we go forward.
Well, it's important to find out. We're going to have if you like, if it's allowed, we have a list of you with your emails and everything. We have a list of the faculty with the emails and everything, so you can use it later on to connect. And we don't have an open chat room because we think this is stupid, because nobody would like an open chat room. You feel a little bit embarrassed. But you can directly ask things like a lot of people are doing. And the thing with me is I'm finding myself every year to ask things to younger people. So don't consider yourself, you know all, because you got thousands of cases. And especially retina, you know what is so lovable to us retina surgeons? You never have a case like the other. And you're full of surprises. And I have surprises every day. And that keeps me alive because I don't know what's coming next. But those poor cataract surgeons, 10 minutes. And then they go to Yamani techniques in order to be excited and have the same feeling. This is exciting. Yamani is exciting. But cataract is you talk to you and you do something. Tell me, Huning.
Do we have sound here with this HDMI?
Well, if you sing, yes.
I'm not gonna sing, don't worry. Just this way. Okay, it will have to be from here. Don't worry.
Is Professor Rusu somewhere in the auditorium? Oh, you changed your color. Oh my God. You became younger. Come in the front line. Come in the front line. You're next, you know.
So,
please take a seat.
So the second video I'm going to present you, it's from all these mistakes and things we have done wrong and about not having resources, we had to find a way. It's called the GRIDER technique. It was presented by us the last year. And I wish you enjoy it, and I'm gonna tell you a history about the technique that came from a moment of extreme need.
A few weeks ago, this patient had undergone a combined phaco-vitrectomy due to a blunt trauma that had induced cornea edema, iris sphincter damage, cataract, and retina detachment. Now he returns to remove the emulsified silicone oil. After removing it all, we are faced by a sticky silicone oil bubble, since the opacified media in the prior surgery didn't allow to complete the procedure. Sticky oil happens when a longer-term silicone oil tamponade mixes with remnant perfluorocarbon, producing an extremely viscous and dense liquid solution that is difficult to be removed. The surgeon might solve it by aspirating the inferior part of the bubble, where the PFO is located, but sometimes that is quite impossible. So, we present an alternative solution, which was found in the oldest sport competition in the world, the America's Cup. Presenting this year the mighty AC-75, a sailing yacht capable to reach 60 miles per hour, we will talk about the crew members who inspired our technique, the grinders. While trimmers are responsible for the boat sail and trimming the loop to get the boat as fast as possible, grinders are at max heart rate during 25 minutes. These guys are responsible for moving the winches, moving the hydraulic pumps, and making sure the boat has enough power to sail around the course at max speed. Here we reproduce the grinder's movements in order to create a centrifugation process inside the sticky oil bubble to agglutinate the PFO droplets. Once they form a bigger bubble, it will be easier to aspirate them, like here, where we can clearly see the perfluorocarbon liquid leaving the silicone. Or like here, where we can see gravity acting on the mixture, and because of its weight, the PFO leaves the silicone oil bubble. Now that the PFO has fallen, the silicone bubble is again lighter than BSS and floats, allowing the surgeon to make a complete silicone oil removal. Despite sticky oil cases are not very common, some months later we had a similar case where we had the chance to prove our theory. This time the sticky bubble was much bigger and the PFO wasn't very clear, but after a few grinds the PFO droplets started to agglutinate again and to become visible. After the PFO aspiration, the silicone oil came up and it could be completely removed. Oops, but watch it. We have a small portion of sticky oil really stick to the retina. So we gently aspirate the PFO first and then, with much attention, we aspirate the silicone part. Since it didn't work, we tried to use the grinder technique on it to see if we could release it from the retina and watch out what happened. Now yes, the silicone oil could be completely aspirated. Remember that safety is always our #1 concern, so you must be very careful when using the grinder technique at the macula, since it shouldn't be touched. Be gentle and delicate. Back to our first case, see how the presence of PFO provoked retinal inflammation. The posterior hyaloid that we couldn't see is now thickened and more adhered. So let's treat what we were not able to do at the first surgery. I hope this film might help you all. Thanks for your attention. And while I finish here, I wish you all a nice sailing.
Bravo, Guastavo. That's great. Another issue is that in the old days, we used to have a system that we clean up the bubbles of silicone oil that they stay behind in emulsified silicone, and that was perfluorocarbon. There was a perfluorocarbon that you injected at the end of the exchange, and it was dissolving everything, because especially the thing is when we exchange silicone oil at the end, when you want to remove it, and you have emulsified, which is a little tiny bubbles, that they tend to get to the extrude, and they produce a glaucoma because they stuck. And you want to wash it out. It doesn't matter if you do this 3 times, in and out, in and out, in and out with gas and everything. At the end, something is going to be left. And in the old days, we used very expensive methods. We used to wash it with perfluorocarbon. I don't know if you can do something in here with the sticky oil if you put some more perfluorocarbon.
It might be in the first
dilute it, because it's diluting the silicone oil.
In the first case, what was a trauma, the volume wasn't very good. And after 30 or maybe 30 minutes, the cornea was totally not, but really opaque, and I couldn't see anything. So I left the perfluorocarbon because I didn't want to damage the retina, and I inserted the silicone oil to keep its pressure, not too much, and because I was afraid of having any phthisis. And after 6 weeks, the cornea was much better. Then I entered again to remove it, and then of course we had this. It was the oil with the PFO.
Well, usually they say that when do you remove the silicone oil? Well, it has to do with why you injected silicone oil. If you injected it because you don't need it as in a simple retinal detachment, you can remove it in a month's time. It's like having gas. If you inject it in a PVR and you still want to do some laser, you still want some peeling, you can leave it and do under the silicone oil some restoration of the retina. But if you have a trauma case, if you have one eye cases, I got one eye cases, diabetics with silicone oil 7 years, 8 years, 9 years, 10 years. And sometimes if I have to remove the silicone oil, you know what I do? I take the old silicone oil and I exchange it with a new one, fresh one. Because the eye is going to become phthitic, or it's going to do a lot of troubles without it. So you must imagine, this is not a question that in 6 months you remove the silicone oil. It's an instrument, it has to be used the correct way, and that's how we talk. Another issue of TVRS is tricks and tips. It doesn't matter how much experience you are. I find myself difficult always to remove the last, if there is a bubble in the anterior chamber of silicone oil, I always have trouble to remove it. And we'll tell you later why is that, which is not the time to tell you, but why it's happening and why I cannot remove it, why it's not easy. And if you see a technique that is used in many ways, that means there is not a good way. If you see many techniques for the same things, that means whoever think of doing anything else than trabeculectomy. So that's an established thing. You accept it. But it's another thing if you see a lot of different things. So thank you very much, Guastavo. And we would like to have Professor Russo